The Bezold-Jarisch reflex is an inhibitory cardiovascular reflex originating from receptors within the heart itself. When triggered, it causes a classic triad of bradycardia, hypotension, and peripheral vasodilation. It essentially acts as an emergency brake system for the heart. Under normal conditions, a drop in blood pressure triggers the baroreceptor reflex to speed up the heart. The Bezold-Jarisch reflex does the exact opposite, making it a paradoxical and clinically vital phenomenon to understand. The reflex arc. The reflex is mediated through an intricate neurochemical pathway. Afferent input. Non-myelinated C fibers located primarily in the infraposterior wall of the left ventricle acts as mechanoreceptors and chemoreceptors. Triggers. These fibers are stimulated by either mechanical distortion, like a severe lack of volume causing the ventricle to squeeze against itself empty, or chemical triggers such as ischemia, serotonin, capsaicin, or contrast media. Central processing. The signals travel up the vagus nerve to the nucleus tractus solitarius in the brainstem. Efferent output. The brain responds by massively boosting parasympathetic, that is vagal tone, to the heart while simultaneously suppressing sympathetic output to the peripheral blood vessels. In a clinical setting, the Bezold-Jarisch reflex is often the culprit behind sudden profound bradycardia and drops in blood pressure. Inferior wall myocardial infarction. Because the C fibers are densely concentrated in the infraposterior wall of the left ventricle, an inferior MI frequently triggers the BJR. Local ischemia and the release of chemical mediators cause sudden bradycardia and hypotension, which can be treated with atropine. Severe hypovolemia and vasovagal syncope. When a patient is severely dehydrated or bleeding out, the left ventricle can pump vigorously while empty. This hypercontractile state in a nearly empty chamber mechanically pinches the C fibers, triggering the BJR. This explains the paradoxical bradycardia seen right before a patient faints from profound hypovolemia or neurocardiogenic syncope. Spinal anesthesia. High spinal anesthesia can cause blood to pool in the lower extremities, severely reducing venous return to the heart. The resulting empty hypercontractile ventricle triggers the BJR, leading to abrupt bradycardia. Aortic stenosis. Patients with severe aortic stenosis are highly sensitive to sudden changes in afterload and preload, which can mechanically precipitate this reflex. Here is a comparison with other cardiovascular reflexes. Bezold-Jarisch reflex. Primary trigger ventricular ischemia, chemical irritants, or severe underfilling. Main cardiovascular output bradycardia, hypotension, vasodilation. Baroreceptor reflex. Primary trigger changes in arterial stretch or blood pressure. Main cardiovascular output compensatory. Drops in BP trigger tachycardia and vasoconstriction. Bain bridge reflex. Increased venous return or right atrial stretch is the trigger. Main cardiovascular output is tachycardia to pump out the excess volume.